Thank you so much for joining us today, everyone. This is our CGD-AA's Coffee and Clinicians Zoom call, and we are very pleased to welcome as our special guest, Dr. Kelli Williams. She is a pediatric allergist and immunologist at the Medical University of South Carolina in Charleston, South Carolina. During her fellowship, Dr. Williams' research primarily focused on rare immunologic and allergic diseases in both children and adults. Dr. Williams has a particular interest in evaluating patients with possible immune deficiencies or immune dysregulation, and she is a CGD specialist. We're very honored to have you here today, Dr. Williams. Thank you so much for joining us.
Thanks.
Great. Well, I'm so glad that you're here. I wanted to just start by asking if you could tell us a little bit more about your background, how you came to be interested in treating patients and carers with CGD, and what have you found in your research when you have treated our colleagues in the CGD community?
Yeah, so I did my training at the, so I was a pediatrician for 3 years, and then I did my allergy immunology training. And I did that at the NIH, where there's a huge cohort of CGD patients, and we often took care of the whole family. And so I was exposed to a lot of patients, and a lot of patients very young, but also very old. And so it was really interesting to be able to see and appreciate the spectrum of disease throughout different parts of the family. But at the NIH, we are very comprehensive clinicians. And so it was always a team approach to take care of everybody. And it gave me that perspective that, when I left the NIH, I think has been really great, because I live in the Southeast and there aren't that many CGD experts. And so I often inherit families, or they hear somebody else who's somewhere nearby. And I think that's great. And I'm very comfortable with it. But I would say that my patients taught me a ton. My experiences at the NIH taught me a ton. And seeing them grow old, seeing them get married, all of that gives us hope and energy to continue to take care of these little ones, right? And so I have taken care of patients who have had experimental gene therapy, and they were older, and this was all from, like a 20-year-old 10 years ago, which was a big deal, right? But also other transplants patients, or people considering transplant. And so I've seen the good, the bad, the ugly, and I'm still here and committed to taking care of patients, because I know how much it matters to have a good clinician to listen to those things. Because you really do need a disease expert when you take care of rare disease.
Absolutely. And just to ask, I think in the past we heard an announcer, or maybe a radio or TV on in the background. If everyone could just mute their Zoom calls, or their Zoom function right now, that would really be helpful. And another thing I wanted to mention is we always recommend that we are providing information, and we always advise that you do see your personal physician as well. But here we are here to provide information to you, and we've also got some really good questions from our community that we want to share with the doctor. And so before we dive into some of these really pressing questions, though, I did want to ask you about some of the research that you've done on CGD patients and carriers specifically. If you can give us kind of some broad brushstrokes about that might also bring some questions to the fore from our community in the Q&A session at the end. So I've read some of your research, but I was wondering if you could give us just like the Cliff Notes version.
Sure. So I will also give my disclaimer, which is, I'm a rare disease CGD expert, but and while there's not a huge list of us in the United States or the world, we all are experts based on our own experience. So, and as we're going to talk about, even with my research stuff, there aren't clear guidelines. Not everything is black and white, especially when we talk about experimental therapy. So my recommendations may not be the same as your doctor's recommendations, but you can, if you have questions about it or you want to have that conversation, I know that any immunologist would love to have a deep, thorough conversation about it, because it is a partnership. And I think both people in the partnership have to be in for, reaching the same goal, which is making sure everybody's here for a long and quality life. Okay, so I would say my research now has been focused mostly on I'm very interested in the carrier state. And it's funny because when I was a fellow, we used to take the samples from the moms and grandmas for all these patients who were coming in, and we would collect it. But it wasn't until just when I finished my fellowship where Betty Marciano's group, or where the group at the NIH was, who had been collecting all the data, actually reported about it. And back in the day when I was learning, it was really more like, oh, we don't know much about them, but they seem a little bit that, their immune profile may not be that, may not be as bad from an infectious state, but their inflammatory stuff was always reported, the increased risk of lupus, for instance. And that was the reason why I think everybody was interested in collecting more information about the whole family. But it wasn't until about 2015, 16, 17, where things started to become highlighted a lot more. And it was just so interesting to me that, like, I just graduated at the NIH where we saw tons of these stuff, and now I'm being told something very different than what I was told a few years ago. And that just, goes to show that our patients teach us stuff, right? They teach us information, and from that information, we have to change the management sometimes. And so I went from just doing genetic testing to help diagnose other people so we can for better provide education to families from a family planning standpoint about the risks of CGD, to now we really need to do genetic testing to help identify what their risks are, their own risks, right? And it wasn't until more recently when I had a few carriers where a mom was like, oh, that makes so much sense. Like, and even when I first met Felicia and heard her story, like, she was a teen with terrible acne, and and everybody was just like, oh, you're a teenager, you got terrible acne. But if she came into me now, I would completely manage that differently. I'd be like, we need to be really aggressive about this patient's acne, because we know it's going to cause granulomas, or it's likely because of this inflammatory state, not just acne, right? And I mean, how many times you tried every over the counter, and dermatologists were like, you're a teenager, you get acne, right? You're hormonal. But it's different now. And so I think that highlighting that and better coming up with management guidelines is really important. And so I'm working with a few other colleagues who feel similarly, who have taken care of really challenging carrier patients in terms of sick ones, some that have needed, I don't know how anybody's needed transplant, but some have been needed hospitalization from infections, or have had really significant inflammatory states. And they are out there for so long sick, but nobody thinks to check a DHR because they're just a carrier. And so I'm working with a few other colleagues to try and make, they're not guidelines, because like I said, this is all gray, but more suggested practice suggestions to help optimize our management for these patients. So the hardest thing I think for us as clinicians is we want to take care of you, but we're like, if you're just a carrier and nobody refers you, it takes a long time. And so by the time they get referred to us, they're usually real sick. And so we're starting our education. It's kind of a two-prong approach. One is targeting all these general practitioners who are seeing you and saying you're just a carrier, to making sure that they are like better attuned to what they need to be, so that then they can make referrals earlier or whenever they're worried. And then the other pronged approach is making sure even our private practice allergists who may be taking care of these moms, like, we know CGD patients often are at the academic centers, but it's a rare disease. You go to whoever is closest to you and hope that they can do their best for you in CGD. But the carriers, even for instance, we need to make sure that our group as allergists are comfortable knowing when to escalate therapy in a carrier, because like I said, our goal is all the same. We want everybody to have a long life that's quality. So that's really a big focus. And then some other things that were, I have an MPH, and so I also do public health work. And so health education is really important. And I think I'm always convinced, and this is probably one of the reasons I was a pediatrician and an internal medicine doctor, is that, if you really take the time to explain why we're doing stuff, that hopefully they'll figure out, and they'll get on board with a treatment plan. But I like to try and give people education about the disease and why we're doing treatments so that they can make the decision and empower themselves to take care of things. And so that's kind of a big focus right now.
Thank
I'm
you.
also, one other thing I'm interested in is working with dermatologists. So to help, they're very uncomfortable taking care of sick people, I guess I would say. And they see a lot of inflammatory conditions. And if things, the thing about CGD patients is they don't usually respond to like normal treatments, right? So they don't know what to do with them. And so trying to help them feel better, have a better toolbox for identifying inflammatory conditions that may or may not be suggestive of immune problems. And so I work a lot with dermatologists to do that.
Right. And that's a point of entry. I mean, many society, you could say, often discounts dermatology. Skin is often looked upon as not so important, right? It's not as serious as other things, but it is a sign, as a symptom of perhaps a greater problem, inflammation and other issues that could be leading to lupus and rheumatological issues. For example, my mother is a perfect example. We've talked about her before, Dr. Williams, where she had skin issues that then led to cellulitis, which is a lethal skin condition, which then brought us to the point where we realized she needed prophylactic Bactrim, and thankfully now she's healthy. She doesn't have poor wound healing, all these other things, inflammation that seems to possibly cause other issues in terms of bone. There could be some bone issues involved too. So, I mean, that's another topic for another day, but to your point that, that the patients teach you. And so we have to be empowered to teach our doctors, because I still hear, that, people don't know what I'm talking about. They often don't believe me. In other countries, it's even worse, where they're not given, even any, credence if they're carriers, that there is any connection to anything that could be, an underlying immune deficiency. So thank you so much for the work that you do, Dr. Williams. And speaking of some of your research, since we have patients and carriers from all over the world who are joining us today, I think I see some people from overseas and across the country and other ports of call. I did want to talk about your really fascinating research about pathogens in different geographic locations and how CGD patients could be more susceptible to things based on where they live. So we just wanted to touch on that as well.
Sure, yeah. Ben Prince, who's a national Nationwide Children's in Ohio, had he headed this group project we were looking at, but it was a great group to work with. And we looked specifically about geographic variability and whether and how their presentation is, right? If, here we might get Aspergillus fumigatus, but other places they get Nigellans, and there's a few different things that may pop up, or like, here in the South, we have a lot of brackish water. So we all worry about these very difficult to manage organisms like granulobacter that are hard to culture, right? And so keeping in mind, basically, weird bugs are weird bugs. Steve Holland says it best, like, if it's a weird bug, it's probably CGD. And if it's hard to culture, it's probably CGD, because the idea is these slow growing things stick around and they don't cause problems in a lot of people. But if they're causing problems and you have to worry about the phagocytes. And so I think that this was a cool paper because we tried to try and figure out like genotype, phenotype, but also like Asia, very different, and Europe, very different, and the United States, very different. We still have similar recommendations in terms of antimicrobial prophylaxis, antifungals, and Bactrim is thankfully everywhere. The antifungals can be variable and how you can get them and what doses. But it's important because we know that they're at risk. And so I thought that paper, it's available for everybody. So Felicia can send you guys probably the link later if you're interested. But
yes, if anyone's interested, please just send me an email. You know my email, guys. Info or Felicia, and I will send you the link to the paper, and you can see where you are perhaps and get a sense of maybe some of the pathogens that you have to it's very interesting to me because I used to travel a lot before COVID and kind of have an international family, and so this kind of thing, and many of us are world travelers. I'm looking at Aaliyah, I'm looking at you, and so it's kind of interesting to think about that.
Yeah, so some of the small things that were highlighted were like, for instance, Japan's numbers are on par with the United States in terms of incidence, but Korea is much higher, right? And why? We don't know that yet. Israel obviously has a higher rate because of a lot of autosomal recessive forms of CGD, but that was interesting to really tease out in the data.
Yes, a lot of fun, interesting data crunching there. I love data and just being able to piece together different things and make correlations that maybe others wouldn't see. I shouldn't say fun. I'm a CGD person, but I do get into trying to make connections and understanding them that might be out there, but then actually, there's something to it. So it's great to know that this is something that we can actually look at, and there's some hard data against it. And it leads to another question. We have a family member from California, and of course, they're planting and gardening and having a nice backyard is great. And she had a question regarding how to think about this for her family member. Is it important to be out of the house when there is mulch being put down, for example? Are there things her family member is not going to be there, but is it safe to use any mulch or to do any composting during installation? What have others done in this situation? Can they grow, for example, potted tomatoes in 15-gallon containers? They try to do this every summer. They use potting soil, compost fertilizer. There's a window right next to the backyard where the patient is how dangerous is this? So these are very specific questions, and just wanted to know what your thoughts are, if you had any advice. And this family member can chime in if she would like to, but just curious about your general thoughts about how safe it is for these specific questions.
Sure. So from a general standpoint, the biggest risk is handling the mulch and then having it aerosolized. It's the mold and some bacteria, but like usually moldy tree bark. It's just like brewing with badness. And so it's bacteria, but also mold. And it's the handling, lifting, aerosolizing, inhaling in all of that stuff. So for instance, once it's all settled, it's not a big deal, right? We live in the South and we just mulched our yard. And so it is a humid environment and it is terrible. I recommend, even like my husband and I are both immunocompetent, and we always wear masks because it's still just terrible. Like, it's so much exposure. The easiest, safest alternative is something that they use at a lot of playgrounds now. It's called rubber mulch. There's no risk for that. It's a little bit more pricey, but it lasts longer. So they use it's like rubber mats, and rubber mulch is what it's called. Turf for playgrounds, that's always a nice thing. But so live trees that were then mulched and potting soil are high risk exposures. They definitely cause severe life-threatening pneumonias, usually aspergillus. And so I would definitely recommend a CGD patient to be not there while they're mulching. In the South, we do this thing called, I don't know, maybe they do it everywhere. I'd never seen it before I moved here, but they blow it in. And so it's a big hose that blows it in. And that is actually a little bit safer because it's not literally it's a huge dump truck that just whoosh, and it just gets sprayed in. and then there's nobody like directly putting it there. And then, but it's the big thing about like being in it and moving it and then like pitchforking it. And so that's the biggest concern. But like I said, once it settles, once it's settled firmly on the ground, and not being spread around or raked, it's much less dangerous. Obviously, like if you have an infant, I wouldn't say like sit them in the mulch while you're doing something, right? Or sit them in the potting soil. But the idea is that it's not like a direct, like they're breathing good air if they're just sitting.
Dr. Williams, it's me who's asking the question. And I actually have, not realizing the implications, I have grown, as Felicia was saying, in 15-gallon pots, tomato plants every summer. And they're literally right outside his office. It's my husband. And nothing's happened in the last 5 years. I'm not saying, oh, I still want to keep risking that. But we would be happy to move out for the whole installation, every time that we do something. I've also thought about using stone as a mulch, small pebbles instead, probably not for the whole backyard, but for quite a bit of it.
Yeah. And I think that would be reasonable too. I mean, the thing about the potting soil is it's really mostly when you're actually doing the potting. Like if you're talking about these, you're not like raking around and like digging up, and he's just coming to pick a thing. So that's okay.
Right.
But he should not be like pouring additional potting soil in pots or anything.
No, he doesn't do any of that.
Yeah.
But
and then for you, like everybody, I always just recommend, like, especially now it's easier with COVID, like
wear a mask.
Just wear a mask. Yeah. Like I said this to my, like our pollen is getting pummeled right now. And he's like, it's terrible. I'm like, just wear your mask a little more.
Right. Nobody's going to care. So if he was to move out, would it be for multiple days? Would it be for?
No, really, it's mostly when it's settled, right? It's like when it's just settling.
So as long as he's away from the house when this is being done, it sounds like it's okay.
Yeah. I mean, yes.
For both compost and mulch.
Yes. Yeah. Okay. He should not be, you do all the composting and then sifting that around.
Oh, we don't even have compost. He's like, no way, we are not.
Okay. I was like most people, even in the South or in my neighborhood, have the composting thing in the way back of their like yard, and then they just bring it back.
Not allowed.
Yeah.
Thank you.
I would think like 24 hours is fine.
Okay, good.
The settling of it. Yeah.
That's really helpful, because when I told him about redoing the yard and I mentioned compost and mulch, he freaked out. Yeah. So
good. It's a good immunologist who's instilled fear, because the number of people who I've diagnosed have been after mulching has been at least 5. Right. And these are like, yes. And it's just like, oh, and they present with like, like a fungal abscess or a fungal ball in their brain or in their lungs. And I'm like, okay, what were you doing?
Well, 20 years ago, when we moved to California, I got some free mulch from an arborist, and we got it delivered literally right outside our bedroom window. We didn't know. And it was a huge pile. So we kind of laugh about it today, but.
And we also love composting. I even have a compost bin in my kitchen, so that's how much I grew up with compost. Like, so for me, I feel guilty when I throw away food scraps. It's like, I'm like, so I should be doing something for this, with this. So I had to get over that for a few years. But now that Sebastian, thankfully, it's gotten through a transplant, I can go back to having a compost bin. So
just real quick, sorry. Just so you know, the rubber mulch, I actually went to the rubber and the stone. I've used both, and the stone I don't like because it's so it moves around a lot, and then it also gets underneath my fence, and so when they're mowing, that can have shooting things. Whereas the rubber mulch looks good, really long, and actually Costco has it for like $7 a bag.
They do?
I didn't know that.
No way.
There's one in oh no, you're in Charleston. Yeah. They use $7 to $9. Like if you catch it on sale, it's $7, I think. Otherwise, it's $9.99. Wow. And it doesn't take that much because it's the rubber, and it's really actually, I like this stuff. I don't even refresh it every year because it still looks pretty decent after 1 year. So
most people say is like, you're supposed, like we for our HOA, we have to mulch 1 to 2 times a year.
Exactly.
But people, if you get rubber, you really only do it 1 time a year.
Wow.
The other thing in the South people do a lot is pine straw, which has its own mold. Its own mold risk as well. And I don't like it. Plus you get snakes. And so
Oh, yeah.
I'm an
Well, yeah, I made them
anti-pine.
take the pine straw away because I'm in the South, I'm in Georgia. And
Yeah.
so I was like, yeah, no, can't have pine straw. And they're like, well,
Yeah.
you'll have to pay for it yourself. I'm like, okay.
Yes, pine straw. I'm anti-pine straw for so many reasons.
Don't like it anyway, but yeah.
I want to see pictures of everyone's gardens, come
Yeah.
springtime. We're going to call this coffee carriers, clinicians, and gardens. I'll figure out the escape there for that. But so this is very inspiring. So thank you. And I'll share mine too, because I'm trying to have a green thumb. And so I want to get through a lot of these questions too, because we are very blessed to get questions from our audience. So GI issues and CGD GI issues and carriers, whether you're patient or carrier, it can be serious. I've had my own issues. I had polyps removed when I was 21. I had colitis symptoms, Crohn's disease symptoms. And so no one knew at the time what that was about, but I suspect, because of this being a common symptom. For patients, it can be very, very serious. And so in one of our calls, last one that we had, one of our members of a community mentioned to another member of a community who's been struggling with this, her son's been struggling with this, that she had tried Actimmune and she found that it resolved some of her severe GI symptoms. And so the member of our colleague who heard that did want to talk a little bit more about it, and wanted to get your thoughts on that. So I'll leave it there. And if she has any other questions, I'll let her chime in as well.
Sure. So I'll start, I guess, more with the general knowledge about GI symptoms. So they're there and they are on all spectrums of things. And from an IBS, just abdominal pain, diarrhea, blood. Blood, it should always be concerning, but a lot of people have alternating constipation, diarrhea, and they just get washed and labeled as IBS. And especially the carriers, I would say, get labeled like that. The GI symptoms can evolve over time. And so it's really important. And I hate nothing more than fighting with insurance companies in general. But if I am worried about a CGD carrier or a CGD patient who's having diarrhea, I get a colonoscopy and then they will say, okay, you're due for another one in 10 years. And I'm like, no, the whole point is it evolves so quickly. And so I think that's the biggest thing is to make sure that you partner with somebody. And it's one thing just to have abdominal pain, and sure, you can see your primary care doctor for that, but you need to make sure that everybody understands it can evolve with time, right? I have had CGD patients who have had no diarrhea and then within 2 years had bloody stools, right? And they are like a normal 10-year-old. And so that's not okay. I think it's important just making sure that it's the same for all of you. You have to advocate for yourself and your child and say things like, okay, well, CGD patients are higher risk for this, CGD patients. And the more and more you say it, you sure can feel annoying to people because you're educating them on these things, but it's important because they're gonna be like, well, this must be true, right? And then they'll like Google it, right? And this is exactly how you talk to half your subspecialists. But it's important because it can evolve with time. And so if you're still having symptoms, the biggest triggers are worsening, not just like chronic intermittent diarrhea, but like all of a sudden, if your symptoms have changed. And I think COVID's actually made this worse because now everybody's symptoms are so much worse after COVID. Like if you get COVID and you had CGD and then you have diarrhea or even hives or rashes, it's just everything seems so much escalated because of the inflammatory component we have with COVID in the immune system that people are chalking everything up to COVID, but that can't be forever. So I would just say, if you have symptoms and they are intermittent but get worse, you need to make sure you're telling somebody because it very much can change. And I think that most CGD patients and carriers are going to need more than twice as many colonoscopies as a normal person. And that's because we worry and we would treat it differently, right? So that's the best thing I write for an insurance company in my letters. We need to do genetic testing because we would treat this otherwise different. Or we would treat, like the big thing about CGD is if someone calls you, Crohn's disease and we're not sure. Every IBD patient wants to put you on Humira, right? And we know, we know that that's not the best and actually can increase mortality in patients with CGD. So we need to look, and you need to look correctly. I have another patient who has an undetermined autoinflammatory syndrome, but similar to a spectrum. And her first diagnosis was Crohn's disease, and she has granulomas. She doesn't have CGD. I don't know what she has, but they've been treating her with every run-of-the-mill Crohn's disease medicine, and it doesn't help her, right? And so there's something, if you identify the pathway, and this is the way that clinical immunologists, we think, is that if you identify the pathway, it can give you insight on how to treat it better and more specific. And we can talk about that again later when we talk about gene therapy. But the idea is, it's okay to be, the greasy wheel and just keep asking. You're not trying, you don't go in demanding colonoscopies, but just say, I just wanted to let you know it's still the same. Or now I'm also losing weight unintentionally. The warning signs for a clinician are blood in the stool and losing weight, or any signs of malnourishment, hair falling out, those type of things, which unfortunately for a lot of autoimmune conditions, it can happen. But, mouth ulcers, those are all things that are worrisome more than just chronic abdominal pain. So the spectrum of GI symptoms can be quite variable, and it can vary with time. And so making sure that somebody knows about it. And that's why even if you see a GI doctor once a year and you're a carrier, you just say yep, I'm just here to let you know it's the same, or it's worse, and we need to worry about it. I think insurance companies pay for colonoscopies every 5 to 10 years, right? Depending on your age. But I mean, they pay for, if you have breast cancer now, you're supposed to get one every 2 to 3 years, right? And so this is a granulomatous condition that we know targets the gut.
Elliot,
So
you had
it's my
another
son.
question?
I was going to say it's my son who has it, and they diagnosed him with Crohn's disease. And we, of course, didn't use the Humira. We using Stelara, but it hasn't worked. We've also used steroids and a bunch of other things. And it's been going on for almost a year now. We're going up to NIH at the end of this month, finally, but he's lost 30 pounds. The thing is that I don't know what we need to, like you said, it's the big thing is they want to diagnose it as one thing, and it's obviously not it, because these medications for Crohn's are not working. So obviously this is not the base for it, but it's harder to diagnose it because then what is it, even though these symptoms, and so then what is actually going to work? And it's just getting, it's difficult when there's nothing that seems to be working, and it's not getting any better. It's actually staying the same or getting worse. So it's kind of like how do we figure it out? What's causing all this inflammation? When we've done the colonoscopy and it looks fine. These are the things that we've already handled, but still it's just not.
So Krista is great, right? This is Krista Zerbe's baby, right? She loves to do CGD colitis. And so the biggest thing is, so we should call it just that, right? CGD colitis, because if you call it Crohn's, then, and there are, inflammatory IBD doctors, they are smart and they think in pathways because they have to use these agents. But if they don't understand, the actual driving it, right? So it's a little bit different, the actual trigger of it. And so it's important, I just write CGD colitis, and I don't write Crohn's, but I say with granulomas, because if you do, they will think it is just like Crohn's. And so they don't ever think outside those pathways. And so at our institution, ustekinumab, so Stelara works great usually, but Veto is something that a lot of Crohn's IBD doctors will consider. Our IBD doctors here love vedolizumab. I love it for a variety of immune deficiencies. So that's probably what they'll talk to you about, but you can talk about it as well. That's an infusion, so it's a little bit more annoying, but patients do well on it and it's well tolerated.
So is it because I guess that was is how long, is it a forever infusion or just until it brings down the inflammation that's causing all these issues? So that's another, and I realized that he said that if we go off Stelara, and has to go back on it, it won't work anymore because I guess his body will have built, antibodies against it. They can
build antibodies. Yeah. So what's the long-term plan, right? So then the next question is, right, what's the long-term plan? Because it's really targeting, the answer is he needs to be on it. And, this is going to be a later question too, is are we using these medicines for bridging until transplant or bridging until gene therapy? Because really we need to fix the neutrophil function, right? And so sure, CGD colitis can get worse at times, but so can any, autoimmune condition. But if you don't fix the actual ultimate problem of the inflammatory pathway, then it probably will come back, right? And so for vedolizumab, you have a buildup and you do induction until you get to maintenance, and then I think it's every 4 to 6 weeks for maintenance. But yes, he couldn't eat it until he gets transplanted. In 2020. I think it was 2020. Let me look. The PIDTC group, Jen Lighting. Let me pull it up real quick. Not that one. They had that paper. I presented it. Oh no, yeah, we wrote something about it in American Academy of Pediatrics, like a review of it, but it was specifically looking at CGD colitis in transplant patients, right? So the question and the thought for immunologists was like, some people were like, oh, they're so sick, you're too sick, we can't transplant you. And they were delaying transplant because these kids were so sick from their CGD colitis. And then they looked at these patients, and I can send you the link if you want to share it to them too, Felicia. But yes. They looked at it, and actually the majority of patients, their conclusions here, let's pull it up. Greater than 80% of all people who were transplanted had great survival after 2 years. And at least 90% of CGD patients with a history of colitis at baseline had complete resolution observed within 2 years of transplant. So like the idea for that paper was like, don't delay transplant because of the colitis, because it actually can fix it too, right? And it can fix it and they still survive and do well. And so it was a big paper for us to say, like, this is all of our transplant centers, right? We're doing CGD transplant and we're looking at these high risk sicker end patients, and they are still getting better. So that's just something to consider, I would say, Aaliyah. Not, obviously I'm sure you've already struggled if he's 10 now with like when to transplant, what to do, but the idea is for colitis, sure, we can manage it and it's a really good band-aid. It's, it's kind of like Actimune, right? It's good. We'll keep you under control. You can decide what your long-term goals are.
He's actually 19.
Oh, sorry.
Yeah, no,
I'm so sorry.
It's fine. He wasn't diagnosed until he was 10, actually.
Okay.
So well, no, it was, he's 19 now, and like, it's been a bad year for him. So it's like, and the infusions, he's afraid of surgery. That's his biggest thing. That's why, I mean, not that gene therapy isn't surgery, major medical. I've been holding off, hoping that would be a resolution for him down the line versus the transplant, because like I said, he was diagnosed so late. At 10, that's already a difficult time to do it and finding a match, because we have all kinds of mixes in it. So I think finding the match is one of the harder things for us as well. That might actually work for him. So the gene therapy thing is like I'm really hoping that gets a little quicker and further along, so that becomes an option for him.
I think their groups, so that's Don Cohen's group and Carolyn Kuo, and they published some very early, some early stuff a year and a half ago, and it was very promising, right? So they're still showing proof of concept with the CGD population, but everybody did well, and the vector did well. So I think 6 out of the 7 had long-term survival, and the vector did very well. So, that's the biggest thing when you talk about gene therapy, right? Nobody wants to get rid of one thing to give you cancer. But I think that they're going to have more data soon. And I think that is very promising. Yes, it's targeted therapy, right? So immunologists love that, right? We want to give you the best outcome with the least risk.
Yes, and I'm familiar with the study that Dr. Lighting did as well regarding transplant outcomes. And if anyone wants that, I could share it with you as well. If I think it's available, right? It's already been published. I know that she was talking about it at PIDTC. So it sounds very promising. So and I was thinking about everyone who's been experiencing this, and so. Do you have any more questions about GI issues and what because it's definitely a tricky one to treat, and so we'll be following that. And so that brings us to the next question, which is about transplant. And as everyone knows, my family's gone through it. Thankfully, we're on the other side. And the question is, what goes into looking for a transplant hospital? Should we be looking at transplants, for example, that specialize in GI, issues, going to transplant, that have a good, GI specialist on staff? What are the things that a patient, a family should be looking for? Certainly experience in CGD, but many patients and families will say, well, we're so burdened with this disease as it is, traveling somewhere, going somewhere. It's really hard to fathom that. So what do you say to these families who are thinking about transplant, looking into centers, trying to make this decision?
Yeah, I think it's a really hard decision for anybody to make. And I always tell people the most important thing is, like, I can give you all the information, but you have to be the one to ultimately make those decisions, right? So, it's too difficult to, family support in a transplant, even if you're local, is essential. And so, traveling just adds another layer of stress on your family and your own psyche. And so, but the biggest things I think are, what's going to keep you up at night more? Is it that you feel like you're going to a center that isn't going to serve your kid well, or isn't going to be the best? Everybody wants to go to the best, but there are a lot of degrees of best, right? There's, when you were a kid, you might have taken 80% on a test because or a 90% or 100, but everyone wants to be the best, but the outcomes are there are some places that outcomes are, significantly better. So I think as you go places and you think about this, I tell all my patients, whether it's SCID or CGD or whatever, ask for their transplant outcomes, look at them and talk about the people who don't do well, and then talk about the people, the average patient, right? There's always people who don't do well, and there's always people who do great and cruise through, but let's assume your kid's going to be average. What does that look like for you? Do they have mild GVHD? Do they not? Because one, everybody's goal is to survive transplant, and two, everybody's goal is to have a better life after transplant than you did before. I think that that's really the main thing. And how we can achieve that is a partnership. You have to trust your transplant team, you have to trust your immunologist, and you have to trust yourself and what you can provide. If driving 4 hours to a different center every day is, or on the weekends to come home and see your other family, you're gonna have a fragmented life. That is very challenging, and you may survive it, but you may be mentally very stressed from it. I think unfortunately insurances dictate a lot of this, because if you're state funded, like my patients on the border of North Carolina, South Carolina, sometimes will get denied if they want to go to a certain, a SCID center to do a certain protocol or any of that stuff. But if you're commercial pay, it's a little bit easier, and some places will only pay for you to go to PIDTC centers because they want you to have the best outcomes. Sometimes you can have people write letters for it. But you want to know the data. I tell everybody to shop around in the beginning, because your wedding dress, how many dresses did you try on, right? It's this is a huge life-changing thing for you and your family, and why not? And if you can't go anywhere, then maybe you don't need to shop around. But if you are truly considering those options, I give people one of three options, and I give them a different things, because there are some centers that are going to be just cord blood, and there's some centers going to be just bone marrow, right? And then you should go to your local center. You should always go to your local center. My local center, we don't transplant nearly as many people as Duke, but we also weren't JMF. And, the only way they're going to gain experience is by transplanting more. And their network is a very good network, and they use the same types of protocols, and they won't do anything that I will say, let me see what you're doing for my patients. This year alone, we've transplanted three PID patients. And that's more than we did the 2 years before, right? And it's because I think we've started a better relationship of between us in partnership and making sure that they're doing what's best for those diseases. Because again, like I said in the very beginning, like I'm a disease expert. I'm not a transplant doctor. I can give you my opinion, but I know the disease and I know what the complications are post-transplant. I know what the complications are pre-transplant. And so I think about things a little bit differently. But I do think it's just a personal decision, but there's no harm in shopping around. It can just cloud your picture and make the decision more confusing, but there's no harm. And this is a huge decision for you and your family. But that being said, if you know that you can't up and move because you have 3 other kids and you have one of your parents have to keep working like to pay for all of this, it's just not happening. That's okay too. Nobody's going to want to transplant a person. Nobody's going to sign up to transplant somebody who they think they cannot successfully transplant. They just won't do it. And it's because they're at risk for losing their transplant program if they think that they're like a high risk, right?
That's right. And we experienced it ourselves with, not being able to find a bone marrow donor, having to shop around looking for the best places that had cord blood with an, unrelated, actually like lowest possible match you could get. And, so we, and all those questions about work and everything, how would we do this, fighting with insurance companies? That I have to do another blog post on that alone and, fundraising and everything else. So just thinking about it is so daunting. It can be really just overwhelming. And so these questions are always on our minds. And just to, we're getting at the end here. We've touched on some of the other questions that I had about carriers and gene therapy, and so I just wanted to open it up and see if anyone else had some questions that they wanted to ask, and that maybe Dr. Williams had mentioned you wanted her to clarify another point or something related or something completely different, because obviously she's a really good source. If not, we can go and delve into some of the other questions that I had. So if anyone would like to ask a question, you can raise your hand. If not, then we'll just continue with some of the things that I wanted to ask regarding this issue with carriers that you had talked about briefly, but I wanted to unpack that a bit. As a carrier myself, we have a hard time advocating for ourselves, a hard time feeling empowered when we're with our physicians. And so we have a hard time even caring for ourselves because we're so busy caring for our sick children, or we're not in that mindset. So what kind of advice can you give to carriers to care for themselves and just give them a little nudge to do that? Is there anything that you could do to tell us that we could prevent things that you've seen carriers, experiencing, that if they had just treated it earlier, like if they had gone to a rheumatologist, if they had done, taken some measures with their GI, maybe even, thought about their nutrition, that they could have prevented certain things from progressing? And how can they also be taken more seriously when they're at the doctor? Certainly we have some educational materials that we ask or advise our carrier and patient community to take that write out the symptoms, the recommended specialist to which they could be referred so that, they can put it in their physician's hands. Is there anything else that you've seen that has really worked with sort of an unaware or maybe a little bit, maybe just not as familiar kind of physician that's not taking carriers and even patients as seriously?
Yeah, so I think the problem is mostly twofold, and it's both it's not an internal problem, but it's like a under-recognized problem, because for the majority of your lives, you guys have had these problems all along and have had no explanation for them, right? It's like, I've been living this life and then all of a sudden you're telling me something else. And so it's more of an under-recognized problem because you've been living with it and nobody cared for the last 20 years. Why all of a sudden should you be telling people different, right? And so that's the biggest thing, is like it's an under recognition. And now you have to learn or change the mindset to advocate for yourself because you are worried, even though everybody told you not to worry for the last 20 years. Right. And so I think that that's the place where you guys need to focus. And so even using this as a platform to come out with that, like you need that and you need that support. And I'm going to work with other physicians to give you street cred so that when you go into your doctor's office, you can be like, here's the thing, you need to think about this from a multidisciplinary area. Right. So that's the side of you guys, is more like you just need to learn to advocate and continue to show up and hope that your doctors are not going to continue to discount it, right? And then from our standpoint, I need to work with other providers. And that's why it's important, like when we write these guidelines or practice white paper, it's mostly to make sure that those people are aware of it. You can't just say, oh, but you're just a carrier, right? Because we know that there's actual disease manifestations that can happen, so you can't ignore it. But it's not that you can't change that. We need to do that. So really, honestly, what needs to happen is the big dermatology paper needs to have a paper about it, the big rheumatology paper, the big GI paper. And those aren't going to happen until we have like a general statement of like, hey guys, you need to think about this differently, right? It's a huge mindset change for providers because there's so many X-linked diseases that's not the case of. Like even from a geneticist, even from a geneticist standpoint, like they're like, oh no, it's not a big deal, right? You're not going to perpetuate it, but they don't care. And anyway, it's not that they don't care, it's just they don't understand that it really can affect the way your lives are going to be in the future. And so I think we need to work more with the doctors, and we will do that. But you guys as a group also just need to continue to advocate that for yourselves.
I am learning so much. I got my question in, guys. I'm glad all of us got our questions in, because when I go to my physician, my general physician, I am trying to be empowered too, and trying to, as Dr. Williams said, shift my mindset, because we've been living with all these things, from joint issues to feeling, we have chronic fatigue. We didn't even get into the mental health aspect, anxiety, panic attacks, depression. And so these are all the things that many carriers live with. And to get into the shift, like, oh, I actually don't have to live with these. I actually can have a better quality of life. I could hear in Dr. Williams' voice the passion that she has for us and how she is committed to our community. And it makes me feel so good. And it gives me the drive to have this passion too, to take care of myself, take care of our community, to help you guys take care of yourselves too, to encourage you that this is your life. This is your time, that you don't have to live with things that you might feel are holding you back, that there are treatments available, there is help available, and you should be taken seriously every time you go to the doctor. And as Dr. Williams said, it's our opportunity to educate them, and they learn from us. So never be afraid to school your doctors, right? So I don't know if anyone has any parting words, but we're getting to the end of our hour. Is there anything else you'd like to add, Dr. Williams, before we close?
It was so nice to see all of you.
Happy to share what we can. And thank you everyone for joining us. And if you have any questions or would like to be in touch with anyone, Dr. Williams, please email me, and I look forward to being in touch. Thank you so much.